Hello, everyone. We are live. Good evening, everyone. So, welcome to the first online event of our Bioethics Unit by SIMSA. We're very glad to have you, with all of you, join us today, and all of you here, and those of you watching in the live. I'm Samyukta Venkatesan. I'm the General Secretary for the Bioethics Unit for SIMSA, and I'd be moderating the session today. And I'll also like to introduce my co-moderators. We have Varshini and Meenakshi with me. They're my very talented unit members. And thank you all so much, all the panelists here, for joining us in a time like this. So I'd like to start about a few words about the topic. Our topic of interest today is defensive medicine. So, all physicians, all doctors have to take an Hippocratic oath, and that is always to do benefit for the patient. And that is something every physician has to follow. But when you look at the reality, when you look at the practical sense of it, no one, it's, give me one second. Do you guys hear that? Okay. So continuing with what I was saying, so every physician has a Hippocratic oath to follow, but in reality, it's not like that. It's kind of alarming because there's something called defensive medicine that's being practiced nowadays. So in a very short term, defensive medicine is when you go deviate from a normal standard medical practice just to safeguard yourself from litigation or any legal suits that you might have. So this occurs when doctors, they give more tests, more procedures, more treatment, more visits, just to safeguard themselves from any liability that may follow in the future. And they do this to escape from malpractice claims or medical negligence claims. And it's very disturbing because it damages, it poses a lot of risk for the health of the patient. It increases the cost of the treatment, and it has a very huge effect on the doctor patient relationship. And that is why we need to talk about it today. And I think as medical graduates, apart from the academic stuff that we learn, the what happens in real life when you practice medicine, the practical and the technical difficulties, it's way more important, and that is why we need to talk about something like this. And again, this panel discussion is conducted by the Bioethics Unit of SIMSA with an internal collaboration with our lovely activity councils here. And having said that, I'd like to introduce our lovely panelists. So we have the chair and vice chair of Courage, Chetana and Shreya with us. We have the chair of Komi, Abhishek, and we have the chair of Corp, Manasvi, and the chair of COF, Snigdha. And I request the panelists to keep their videos on whenever you're speaking, and make sure your mics are muted just to to avoid any disturbances that may occur. And we can begin our discussion by discussing the current state of situation, and all of your perspectives. All of you belong to different activity councils, and I think it'll be insightful to hear every perspective from a council point of view. And I think we'll start with the Council of Medical Education. We have the chair, Abhishek Velmurugan. You can go ahead, Abhishek.
Yeah. So hi guys. So as we are hearing the word of defense, you can hear me? Yeah. So as we are hearing the word of a defensive medicine, so it's a medicine that is practiced for the defense of a doctor. So as in a medical education, so we can see basically two types of practice that is a positive and a negative. So positive, like what a doctor can do for his defense. For example, if a patient is coming for a particular test from a particular disease, so we can offer different tests, and some tests are like generally not necessary, but we are doing to prevent the possible complication. So in one way, we are seeing ourselves for the ongoing impact that can have a doctor, because if we misdiagnose it if we are telling, okay, these patients can have different diseases, but we didn't do the proper test. So we are doing for saying of ourselves. So this can be one aspect of defensive medicines. And another things you can tell, for example, we are just avoiding the patients. Like if a patient comes with a risk of complications, if we denied to saving ourselves, because it's not in our hands, we're just a human being, we are not a doctor, we are not a god. So we are doing whatever possible from our side, but the patients take in a wrong sense and they files a complaint against us. But we'll try to defend ourselves in many ways. So if you see in the Council of Medical Educations, or in terms of medical education, so we were taught of how to have a patient doctor relationship. That's one of the main things that is necessary for a defensive medicine. So, and one more thing is that you can see the patients giving the fake history. So it's necessary for doctors to know they have to have the background check. That's really very important. So giving the like fake histories and all this we have to taught in a medical curriculum, like how we can deal with the medical negligence. And negligence can one of the key aspect of the defensive medicines. So if you see medicine is imperfect science. We are only medicines based on what the clinical things that we have, and we're just forming the guidelines and we're just forming the treatments, right? So it's always changes. So, and it's one of the good things that I can tell, that we have to defend ourselves for all the possible causes. But one more we have a cons also, like getting the benefits of that. So still we are progressing, so we have new technologies, and even though this field is not clear, but I guess defensive medicines and medical education should involve more, because always in a medical doctors or medical students, we're always learner. We doesn't come to an end like, okay, this is gonna happen and these are perfect things. So we have to adopt with the situations, and whoever it may, we have to try to defend ourselves. It's for a betterment for a doctor, or it's a betterment for our patients also, like for the further perspectives or for the further course.
Right, yeah, I agree with you. Medical profession is like a lifelong learning experience. It keeps changing as the years go by, and it was very insightful to hear about the positive defensive medicine, the negative defensive medicine, how you deny treatment for a high risk case or something. That is negative defensive medicine. Thank you, Abhishek. We'd be hearing next from Koraj, Counselor of Sexual Reproductive Health and Gender Education. We have the chair Chetana Rajesh and the vice chair Shreya Durbe. Over to you guys.
Hi, thank you so much, Samukta. So I'm Chetna, she introduced me, and I am the chair. So, before delving into the topic proper, that is defensive medicine, today I would like to say that whatever we here as medical students discuss is in our capacity as medical students and in a very limited capacity of clinical exposure or whatever we read of the internet and understand from that about defensive medicine. We ourselves have not been in the position of a doctor wherein we are responsible for a life. One of the I'm big on personal anecdotes, so I'll share this from my personal experience. That the first thing when I told my dad, I think that I want to take up medicine, he was like, medicine comes with a lot of responsibility. You are responsible for a human life, and imagine how scary that is. And then with the increasing liability litigations that have been attached to medicine, see, it's not surprising that a concept like defensive medicine is emerging. And even if we are not strictly as medical professionals practicing defensive medicine, it is creeping into our mentality, because, when you tell teachers something like, for example, this is a very simple example. Again, that day the medicine viva is going on and someone says, okay, so my patient is an alcoholic, and they're like, how can you label him an alcoholic without the proper requisites? If you label them an alcoholic in US, you'll be directly taken to court. Imagine someone is studying for 4.5 years, who's probably going out of their mind in their medicine viva, and there only the thought process is starting, that if you say something like this, you will be liable. So see, again, defensive medicine as a concept, in my opinion, is more a matter of perspective, because no medical professional sets out to harm their patient, because we all do this at some level to help our patients and to help them reach the best outcome there is, and to avail the best treatment out there that there is for them. And we don't succeed always, obviously, because like Abhishek said, I agree completely that medicine is an imperfect science. But medicine and ethics is contingent upon a central theme, that is the doctor-patient relationship. So, the key takeaway from reading about the concept of defensive medicine is that we need to work on our interpersonal communication. We need to help patients be less scared. And as doctors, we need to be more communicative in helping the patients understand, what is happening, why is it happening, why is every test being done. We might not have time always, but maybe, if we do take out time to interact with our patients, there could be a difference that is made, because that doctor-patient relationship, if you see, is central to each case wherein negligence has been established or wherein there has been some sort of conflict between patient and doctor. Another thing we are in India, we do realize, the increasing instance of violence against doctors. We have all firsthand seen how it has been in the past few years. Every day, every few months.
Chetna, sorry to interrupt. We can't hear you.
Oh, you can't?
Yeah, okay, now I can. I think your hand was on the speaker or something.
I'm so sorry.
Yeah, okay, continue.
So I was saying that, we all are aware of the increasing instance of violence against doctors in India. Every few months, we read articles about how the violence against doctors has been rising. So again, that atmosphere of apprehension and that atmosphere where we cannot trust the healthcare system to be safe for doctors themselves, right? That atmosphere has been created, and that is further contributing to the overall declining nature of the doctor-patient relationship. And that, in my opinion, is what is giving rise to a concept called defensive medicine, that is, more of a matter of perspective. And again, like I said, if we do work on better on our interaction, and that is what, if you see, our medical curriculum is also switching towards a more overall development, a more professional development of all our skills, including how we communicate with the patient, is given a lot more value than theoretical knowledge. So having said that, I would like to hand over to Shreya to present the rest of the take of my counsel on this topic.
Hi everyone. So I think Chetna covered everything beautifully, and there's not much that I need to say. It's just I just have to point out that we need to take a different take on defensive medicine. It's not a blame game. I personally do not blame doctors, because, like Chetna said, just the fear. Like, imagine most of us don't just finish MBBS for 5.5 years. We go on to do specializations and super specializations, and that takes around 10 years of our life. Imagine making a tiny mistake and just foregoing the 10 years of our life, the high fees that we pay, and just all the education and the time we have given up to become a doctor just for a simple mistake. Sounds very scary to me. And like Chetna has mentioned, even Samyukta towards the start of her introduction mentioned, the doctor-patient relationship is at the core of this whole thing. Earlier in the olden days, there was this trust between, and I'm not saying it was right or wrong. It was just there that in the olden days, someone would come into the clinic and, someone would blindly listen to you. If a doctor prescribed something, they would just blindly listen to you that, okay, this is how it is. Okay, I respect this person. I'm going to listen to them. Now, with the advent of Google and, Wikipedia and WikiHow and, just WebMD, it's become like, you Google your symptoms. No, doctor, I have this. That trust and the faith, I don't know how right, wrong it is. It is good that the patient is more aware and doesn't just take the doctor's word for it, but word for anything so easily. But, just the fact that, now the dynamic of the relationship between a doctor and a patient has changed so much that, I can't blame the legal system. I can't blame the healthcare system. I can't blame the patient. It's just that times are changing, and we need to get to the core of the problem instead of focusing on they shouldn't do this or they shouldn't do that. Because yes, of course, you shouldn't be doing it, and it is not a. I wouldn't say right thing. It's not a right thing, but I feel like getting to the core of this, the doctor-patient relationship, why it's happening, and understanding, being more empathetic towards healthcare providers as to why we follow such practices, or even unconsciously under the back at the back of our mind, we just think that it is better if you give this test, or if it's better if we do this, or it's better if we skip this just to avoid any problems. That's something that we need to do probably. Like, just giving a very plain example, because we are from Courage. When we advocate for the fact that, you have to ask someone for their sexual history. Ask them that, okay, you need to ask, okay, are you with someone? Are you currently sexually active? But I don't think I have ever been to a gynecologist and have been asked that question. And somewhere in the back of my mind, I also understand that, the reaction I might get from my patient, if I have to ask that to a person from the rural healthcare setting, if I have to ask them, are you with someone who's unmarried? I don't know what reaction I'll get, because Chetna has so very rightly said, there's an emerging, understanding that doctors are facing more violence. So my take on this is that we need to focus more on why it is that why we as healthcare providers are gravitating towards a defensive form of medicine, and try and work on that before we work on anything else.
I think that was very beautifully put by Shreya and Chetana. And I totally agree with everything Shreya said. It's not a blame game. It's not like the patient is right or the doctor is right. It's definitely, we have to get to the core of the problem. And as Chetna mentioned, like, the situation is worse now, with all patients being educated. It's a good thing that they're educated, they're coming up, and they know they can stand up for, what they know is right and wrong. But at the same time, are the protection laws good enough to protect the doctors on the other side? And Chetana mentioned about the Viva situation. I think for me, it's when I've written wrong doses for pharmacology, and it was a terrible experience. And I think that there was this huge lecture from my professors. They told me how, a single dose could probably kill someone. And, you can't make this mistake. You'll probably be jailed and you'll have your license revoked. So, yeah, when you have that on the back of your mind, it is very difficult to, go ahead, trust your instincts, basically. You keep over-doubting, overestimating your risk. And that was very well put by Shreya and Chetana. Thank you. We'd be moving on to Council of Public Health. We have the chair, Snigdha Mishra. We'd love to hear from you, Snigdha.
Hey, hi guys. Am I audible and am I visible?
Yes, you're audible and you're visible.
Okay, hi. Okay, so I'm also big for anecdotes, and I would like to begin my take on this. And just just bear with me. So I come from a family of doctors. My parents are doctors, and my mom is a very renowned and established gynecologist who started her practice around 25 years ago. Right when she started her practice, there was a delivery in her hospital where the baby was born with genetic defect, and this expectant mother came into the hospital with in an emergency situation, and she was not a case that my mom had taken up during the gestation period of the baby, but it was an emergency situation and the case was taken up. The baby was born with genetic defects for whatever reasons. I'm assuming that the previous doctor had not really taken a lot of precaution and prescribing certain not prescribing certain drugs, or giving the cautions to the mother. But the baby was born with genetic defects, unfortunately, and it could not survive after a few days. And 3 or 4 days after the birth of the baby, my mom's hospital was vandalized to the core that it had to be rebuilt all over again. This happened around 1997 or 1996. So as much as I would love to sit here as the acting chairperson of Council of Public Health and side with the public, it is a little it is a little difficult for me as somebody who is a medical graduate, and also as somebody who has grown up seeing the ins and outs of the profession. I truly believe that there are two sides of every coin, and this defensive medicine lies on this very fragile balance between the two. While I really, after a lot of research also, I cannot make up my mind whether defensive medicine is a good thing or a bad thing. I definitely believe it is a necessary evil. As Chetna already stated that, that subconsciously it is seeping into our, minds that, defense, like to act in a more, defensive way from our own side. I truly believe that it's a very human instinct. If I can be a little philosophical and a little biological, I think it's a very fight or flight instinct. And unfortunately, it's come down to the situation because of the policies that the government has, brought out for doctors, which are not really doctor friendly, and also the lack of support from people. I'm all for understanding and empathy, but what happens in a matter of 30 minutes and in a high octane situation of an emergency surgery with technical difficulties, with all the measures that we have to take as medical professionals, is something that only the people from the medical fraternity can understand. And there has to be, I truly believe that while there has to be transparency from the professional end of doctors, I also believe that there has to be a certain level of understanding from the general public. So why I stated the case from 1997 that my mom faced, the reason is that I hope that in 2021, 21 years into the new millennium, I hope we are at a place where defensive medicine does not have to be a thing, but unfortunately it is. Because the situation is so dire that we have no other option but to over-test, over-diagnose, and that is unfortunately leading to it's a vicious cycle. The doctor is scared. The doctor is sending out this list of tests that the patient has to take. Otherwise, he will not come to a confirmatory diagnosis. He will refuse to offer treatment to the patient. That leads to this financial burden on the patient, which again forms this mentality that doctors are just out for financial gains in all of this. What people are failing to understand is that we're stuck in this cycle. It's coming from mistrust. It's coming from misinformation. And it's also coming from the fact that the government is not supporting us. And that has been the case for quite some time, or otherwise we would not be in a situation like this. As Abhishek already stated, that there is positive defensive medicine and there is negative defensive medicine. And I truly believe that there is a time and place for both of them. Because I think if a hospital or a small practice is not equipped for something as dire as a brain aneurysm, them taking up a case like that would actually be fatal, not just to their own practice and their careers, but also to the patient. So in a situation like that, defensive medicine is actually a very good thing, because if they're referring to the patient or refusing to take on the patient because of lack of resources or skill, I think it's a good choice. There is no problem in accepting that you're not equipped or you're not up to the mark regarding certain things. I think that is a sign of progress and growth, and that is necessary. And similarly, it's also a good thing at times that we are practicing positive defensive medicine, because testing and with newer technologies, I think it's necessary that we are utilizing those technologies to make the best of what we have. However, the only fear I have is that defensive medicine is turning our generation of doctors into into dependent puppets, if I may say so, without offending anyone. Because from what I've heard growing up from my parents, most of the people from their generation were just MBBS graduates. They did not go for specialization. They hardly any went for super specialties. But these were people who were impeccable in their diagnosis, just based on clinical history, on understanding the concepts of the pathogenesis of diseases, without depending on so many lab tests. I truly do believe that a doctor's skills can be tested right at the basics of how well he can diagnose. So as much as I'm excited for how many tests and newer technologies are coming up for us to utilize, I'm also a little worried where would we be if we didn't have those at our disposal. So like I said, it's a very delicate balance between the two. And I really hope that in the near future, it takes a more positive turn than a negative one, and it benefits both the public and the doctors. And for that, I really hope that the government makes some, beneficial reforms for both. And yeah, that's the take from the Council of Public Health. Thank you.
That was a very beautiful take on defensive medicine, Snigdha. I mean, we've heard from most of our friends and all, it's mostly supporting the public. There's unnecessary tests, increased costs, quality is, decreased. But, this is a very new approach as well. Doctors don't have anyone to depend on, so they have to take drastic measures themselves. That is a very interesting take on this, and I think that's why we're discussing this today. Thank you so much for your views. And moving on, we will be listening to Manasvi Reddy Maram. She is the chair of Council of Rights and Peace. Over to you, Manasvi.
Hi, hello. So actually, I think there's a very fine line for defensive medicine and again, evidence-based medicine. I believe anything that is done for therapeutic purpose of the patient does not come under defensive medicine. For even if it's reassurance, even if it's to confirm diagnosis, I do not believe it comes under defensive medicine. But anything that is done for personal protection would come under this category. So again, in human rights and bioethics, we usually follow these three principles: autonomy, beneficence, and non-maleficence. Autonomy is where we respect patient decisions, but here the doctors are worried more about their own interests. I would say again, defensive medicine is more commonly practiced in the US than in India. Personally, I have not seen that extent of harm caused by defensive medicine here. Again, this is increasing because of a recent increase in malpractice cases, and that could be because of increased awareness, increased education of human rights, also due to media miscommunication, right? And also, yeah, there are a few lawyers who would encourage patients to sue their doctors. There is some amount of compensation which goes to them. Again, recently, my microbiology professor was telling about this very rare patient. He presented with some lesions, went to the dental hospital attached to our college, and there were lesions in his mouth. And then I think it progressed to skin lesions, and they just referred him to the dermatology department. And then I think by the time he went to the dermatology hospital, he had swelling in his eyes. So they were just like, it's not our case, you should go to the eye hospital. And he was sent to the eye hospital. There he developed a cold. So they were like, oh, this is something related to respiratory. So, refer to the respiratory, not our case. Respiratory, they say, we found some nodules, it could be cancer. They go to the cancer hospital. Then when they take a biopsy in the cancer hospital, they just find multiple microorganisms. And then they were again referred back to the general hospital, where samples were taken from the lesions and sent to our microbiology department, where they found out it was a very rare fungal disease, post a complication of COVID, like post-COVID complication. So again, this is a type of negative defensive medicine where we are avoiding that patient continuously, where we could have just taken a simple test. Instead, we have overdiagnosed that patient, and probably if there was much more delay, it could have led to death of that patient. Now, again, because this is a government sector, patient suing doctors in a government sector is pretty rare, right? But if this was a private hospital, then there would have been a huge malpractice case. So that is where I'm in a dilemma. I don't know where to support because I've seen both sides. Again, there's both sides of the coin. Um, but again, before entering into MBBS, I was putting the entire career field aside because I was scared that, doctors are treated as gods, and I don't want to be a god. We are humans. We tend to make mistakes, and I think in 2019 there was this huge surge in violence against doctors, which made me feel like, should I really take up this profession, risk my future? And this, while here, at least in the US, I think it's a systematic procedure where you go to court, but here your life is at risk, where people are throwing stones at you, right? So that is why we practice defensive medicine. I think it's anyone who does, if it's just for our assurance. So that's my take on it.
I agree with everything you said as well. You can't pick sides, and there is a fine line between this. And yeah, it's the thing is, it's a very new topic as well. It's more common in Western countries, and as you said, it's Western countries is at least the system that doctors go through for all the legal procedures. But here we don't have proper laws, we don't have proper infrastructure, and there is an increasing level of violence here, and it is very it's of interest, and it's very alarming at this point, and Lord knows when we finish our MBBS degrees, you have no idea how the situation will be. And in private hospitals it's worse. Yeah, in private hospitals they'll immediately have a huge malpractice claim and all that. And yeah, I think that was a very good take on it, Manasvi. Thank you so much. We'd move on to the questions. So as this trend sort of keeps increasing, there's a increase in there's a fear of litigation more than the patient outcome. So what is the effect on the cost and the quality of healthcare? And because as much as we think there is an increase in treatment cost for the patient, what about the hospital? What is the quality? Is it increasing? Is it decreasing? Are more tests considered more quality of healthcare? So what do you think about it, Snigdha?
Hey, Samyukta, thank you for the question. I really think it depends on the demographic and also the geographical location. If we talk about something like India, without, throwing mud on our country, I truly believe that there is an exorbitant bridge and gap between the quality and the cost between, of the medical care that is being provided. If you go to a private institution at this point, something big and corporate, I'm pretty sure a patient being admitted for 1 day will cost no less than 1 lakh, including all the bed charges and everything else that is required and necessary for 1 night of hospitalization, probably a day of hospitalization. And I hardly believe that this is justified in any setup, because at the end of the day we are medical practitioners who are trying to provide a good service first and foremost, because that is our Hippocratic oath. But unfortunately, with time, it has become a corporate business where, defensive medicine, which should have and did initially start as a, defense mechanism, has actually turned into a profitable business where people are, taking the easy way out and, sending out these lists of, tests that need to be done before a treatment has to be meted out. So I definitely don't believe that in a country like ours, with corruption like ours, that the gap is closing in anytime soon. But I am very positive, so fingers crossed for that. And if we talk about the Western countries, as far as I know from personal experience and from people who I know who are living abroad, at least the quality is better. If the quality of healthcare that they are getting in return for the exorbitant amount that they are paying is at least better, with regards to the attention to detail. I'm not saying that the medical system in India is flawed, that we are not doing enough from our side. It's just that the balance between the risk benefit ratio that we study in pharmacology, I think, is just not justified as much as it is in the countries abroad and in more developed countries. And I think it has a lot to do with the disparity in the economy and all the rules and regulations that we have here versus what they have there. So I think it's a comparative study that needs a lot more than a small discussion. But I definitely believe that there needs to be a bridging of the gap that exists, and we can only hope for the best in the future. Thank you.
Right. Yeah, that's very true. I think Abhishek has a view on this.
Yeah. So as Signa is mentioning about the developing countries, so as a foreign medical graduate studying in Russia, so I also have like two different perspectives that my friends are studying in India. So I know what is the real cases that India is having at violence against the doctors and a different perspective. But in the abroad countries, you see the documentations that a doctor is doing that's more strong. And India, you can't see. I don't know whether like in India how is trained, because I'm not new to Indian medical curriculum. So over here, it's like we're trained to do all a minute things from the starting from the first thing to the end, like how to document the proper things if you're performing any surgery. So what are the steps you have to write? You have to make it clear like which side you're doing. Suppose you're doing amputations, you have to mention like which leg is that, which portion is that, and what you have done. But if you see the Indian system, just you will be mentioning I have done this surgery and this is the name of the surgery. So when it comes to a kind of negligence, and it's you can tell like something complication happens, and literally the patient blames the doctor, like because of this it happens, but they don't understand what is inside thing. So one of the flaws that we can find in the Indian medical system is the not a proper communication, as we mentioned earlier, and the delay in the documentations or the filing of the things that we're doing. And one more thing you can tell about the medical insurance, that's not more common in India because we have both government and we have both in private. But if you see countries like US, UK's, all the peoples are accessible to medical healthcare insurance and license. So that will decrease the cost and that makes the healthcare way better.
Yeah, I think it was very well put by both of you, and Abhishek and Snigdha mentioned about the cost and the healthcare, the health insurance here, and in foreign countries we have a different pattern of insurance, and how people get their healthcare. So, like, does health insurance of patients, have an impact on to the extent of which defensive medicine can be practiced? I think that is an important thing to talk about, because the one of the main entities here is health insurance and government schemes. So patients on that, does that have any effect on defensive medicine? I'd like to hear your thoughts on this, Manasvi.
Yeah, so in India, I feel like recently, since malpractice is increasing, doctors in the US do have malpractice insurance specifically, but in India, not many doctors know about this or have any malpractice insurance. But because of this rising cases, I feel like this has opened a new market for insurance companies, and especially in like high risk fields such as neurosurgery, right? In that there are a lot of malpractice cases, which is not essentially malpractice, because in neurosurgery I feel like everything is a risk, because the instruments that we use are also in contact with your neurostructures, which are very delicate. But almost most of the cases are in this field, and according to my research, the highest compensation was more than a crore rupees in India, which is not covered again by insurance policies. And unlike in the US, in India, this medical insurance is still covered under broader professional insurances, and it depends on factors such as specialty, previous claims, the doctor's experience and caseload, place of work, where do they work. And if the malpractice was from a case before they took this policy, it would not come under their insurance policies. In India, healthcare insurance, I have not personally encountered such cases, because that would again not come under defensive medicine. If we are prescribing more medications or asking them to do more tests for the case, because we have a tie up with an insurance company, that wouldn't come under defensive medicine. But in the US, because their healthcare system is very different, it does play a huge role. And regarding government schemes, in Telangana, we do have Arogyasri scheme, which I've seen in my hospital. A lot of patients have, which is providing like free treatment for people below the poverty line. And they can, this is not only in government hospitals, but they can also avail diagnostic tests or procedures in private hospitals. And here doctors cannot prescribe extra tests or extra surgeries or any procedures, because everything has to be documented. Yesterday itself, I saw a tonsillectomy, and this was an Arogyasri case, and everything had to be photographed. Everything had to be documented properly, because it has to be sent to the department. So I don't think there's any benefit for the doctors here.
Right, yeah, I think, yeah, I've actually never heard about the scheme. It's very nice to know that, such a scheme exists, and it was very interesting on your take. And yeah, health policies and healthcare insurances, it comes as a small part under a very broad insurance plan and stuff. And I think Shreya has an opinion on this as well.
Yeah. So I really like the way Manasvi put it, and I'm not quite sure how relevant it is. It's just something I wanted to point out that, am I not audible?
You're audible, Shreya. You're good.
All right, great. So, I just think that yes, okay, health insurances exist. Not everyone has them. There are certain policies that our government hasn't, but let's face it, the people from the upper classes are the ones who have the privilege of getting a good health insurance, which covers a wide range of illnesses. But that's just the thing. Something like, let's say, a master health checkup. Now, I haven't completed my education. Someone who has a lot, this is just my take on it, someone who has a lot of money and is capable of getting that master health checkup, whether it is covered by their insurance. I don't know if they should be taking it up, because, getting an investigation done, getting any sort of test done is not just about the money. It is about a lot of other factors that we have to consider. For example, I'm sure you guys have friends, and I have friends who are scared of a simple blood test, and it is actually distressing to get a blood test. Or someone who's scared of injections because they're scared of the pain or having blood drawn. Some people don't like getting MRI scans done. Some people are scared of simply going to the doctor because of a hospital environment, or you have to go to a proper investigator, like a proper hospital, get certain investigations done. A hospital environment is distressing. I feel like it seems very small in the grand scheme of things, but these are certain things that we have to keep in mind when we prescribe investigations. Of course, again, like I said in my previous stance, that we have to also understand why a doctor is so defensive. Why we as healthcare professionals are so scared, and we tend to prescribe more tests, or we tend to do away with certain tests or practices so that we can avoid litigation. But at the same time, we also need to understand that, okay, even if someone has the money or someone has the resources to be able to get a test done, or have a master health checkup, for example, it doesn't mean it needs to be done, because just getting that done in itself can be very distressing to the patients, which can have other consequences.
I think, yeah, that also does make a lot of sense. And yeah, that comes to, you know, what socioeconomic class the patient is from, whether they can afford the treatment. Yeah, that definitely makes a lot of sense. Thank you, Shreya. We'd be moving on to the next question. I'd pass on the mic to my co-moderator, Varshni.
Hi guys, am I audible? Yeah, okay. I guess like Abhishek had some point to add on the previous prompt as well.
Yeah. So as Shreya said about the test, even though we know that the patients are distressed of different procedures, taking CT, MRI, going into the machines at dark fields again and again. The same thing happens for us if we prescribe for the medicines also. If a patients come with different complaints like typical of infections or something, so instead of, we will do clinical blood tests at the initial level, but more going into immunological tests, PCRs, that literally is a waste of time and a waste of cost. So we really tend to give antibiotics, like whatever. It's the only first line of defense that we used to give. And this, we know, like we are, our council are also working on antimicrobial resistance. We know their ill effects also. But if something is further complications arise with the patient, if the health makes more severe if we don't prescribe this medicines, even though people think it's waste, why to have antibiotics for 6 days or for a 1 week of course, but it's really, it's very useful, and we don't know how the patient react and what can be the worst thing that can happen to a patient. So we have to prepare ourselves, even if we're talking about in terms of lab tests, even if in terms of we're talking about the medicines. So it's both beneficial. So at that moment we are being definitive for us, even on the basis of the treatment, on the basis of the prescribing the drugs. So we have the positive sides also, but it's up to us. It's based on the people's level, like about their background. That also matters a lot if you're talking in terms of financial stabilities and financial things.
Well said, Abhishek, like the positive side of prescribing medicines and all. Okay, so let's move to the next prompt. And this is again going to Dr. Abhishek. So I want to know what is the current status of defensive medicine in India. And as we have been speaking for a long time, and we know violence is a major cause why doctors started practicing defensive medicine in the first place. So is there any laws that protect doctors against these violence? And the same violence is why we started taking a lot of tests. So is it correct to take a lot of tests just because we are being defensive?
Okay. So as talking about the Indians Act and Indians rules and regulations, yeah, India recently passed a regulation is Medical Protection Act. So, but if you see it just an act, we doesn't include it in our law system, that is IPCs and CRPCs. So if a patient complains on a doctor, like, okay, this negligence happens, but unfortunately we can't go to court and there's no legal issues. You can see in terms, I still remember recent, there was an attack on a doctor, right? So attack on a doctor's because he denied to attend a patient who is COVID because there's insufficient amount of beds. Okay. And there's a lot of factors that has in India's, we can tell that, but there's not such a rules and regulations that we can have. Mostly things that have, like, if there's a false allegations, they can be jailed for 3 years or like 50,000 penalty, that's it. So if you see in India, the situation is not as good enough with the developing countries, but as a doctors, we are doing advocacies on that. We are protesting it. So we also need support. We also need our safety first, because if we are safe, then only we can able to treat other patients. So we want to defend ourselves, then we can defend the whole societies with diseases or whatever the problems they have, whatever disease they can cure. But India need to look after this, and I guess Indian government are trying to make the laws more strict, but in real life, it's not applicable. Like, it takes a long time to go, but they'll just pass the bill. But coming to actual, if once you indulge into a court case, okay, so if you file a court case to a doctor, it's not gonna happen within a few months or 3 to 4 months. It takes drag long and long and long. Like, some cases are pending and some it's not in the list itself. So there's nothing such, but we are trying to voice we are trying to voice up ourselves to have more against us, because like, if we keep ourselves safe, then only we can protect the whole community.
I agree with you, Abhishek. Like, we had to protect ourselves. We say in Tamil, like, "Tanakku minjiye danamum dharmamum." Only once we have something in our home, we have to start giving for someone else. I guess, like, once we have something to put in.
Yeah, so probably not related to the violence part, but regarding the legal system, uh, like in my research, I found out that in the Indian judiciary, there is no cap for compensation, which does not make sense, right? So the judge, that too, the judge has a complete discretion over the compensation amount. Now, I believe there should be a medical professional over there determining, the grade of injury or what has happened to compensate to the patient. But a judge decides on the compensation amount. There is no cap on these malpractice claims. It's just bogus. And most because of this, again, not 100% of the compensation amount goes to the patients. It's probably just 20-30%, right? Most of it goes to the lawyers, to the law fees, etc. So again, here none of us are benefiting. It's neither the doctors nor the patients. It's again the middlemen, the government, the lawyers who are benefiting here. So here again, they think that it's all drug mafia. This is a term I've heard a lot during COVID here. I've heard a few of my family members say that too. I've heard this COVID wave is false. It's we just saying this because we want more patients so that we can make more money. We don't want to be overworked. We don't want, I mean, who wants wards full of people and continuous shifts without any rest, just because we would make a few more bucks, right? I don't know, where do these claims come from? And on top of that, I feel like our government has done nothing much to curb this, right? It has just put more ghee in the fire, I would say, more oil in the fire, and increased this in the past few months, where even an auto guy, where I was taking an auto yesterday, would be like, "You're making million bucks every day. You can't give me 10 rupees." And I'm just like, where is all this coming from, right? Where is all this coming from? So that's what I wanted to put out there.
It was so relatable. Like, we heard it from all our professors. Like, it doesn't mean like you get in MBBS, you get like no lakhs every month. It's not the truth. Like, I want like public to understand this reality. So we have Shreya again raised her hand. Yep, Shreya.
Hi. So yeah, I think whatever Manasvi said, that's just so true. I think instead of having millions, I think it takes more time to recover from the damage that MBBS has done in terms of money, especially for people who are from private or deemed medical colleges. I mean, that's something that takes a long time to recover. And besides, what we get paid in internship is just sad. But anyways, this just I'm going to talk a little bit on violence, but this just brings just reminding me of what Manasvi said, that I don't want to become a doctor because people consider me a god a lot of the times. And I mean, I relate to that. Like, there's a lot of pressure on us. We are basically Spider-Man. Like, with a lot of power comes a lot of responsibility, sort of like that. We have become that. And a lot of times people say that violence against doctors is increasing because there's lack of respect for doctors. But the more I think about it, this element also comes into play, is that more than that, it's that we are considered gods, and we are not allowed to make mistakes. I just feel like in that sense, the general public, it is, I don't know how to achieve that goal other than saying that, educate them. But, it just feels like, don't treat us like gods. Don't treat us like, we're superior to you. We're just human. We are studying, I'm pretty sure at least all of us, at least I have failed at least 2-3 times, and it's completely normal in a medical college. We study really hard. We make mistakes in medical colleges so that we can treat you. And I just feel like more than being respected, it's just that, treat us like any other human being, because we are sitting here like, like an engineer sitting there fixing cars, because they have studied for the years that they have studied and to become an engineer and learn the mechanics. We have studied for the years that we have studied to treat you. So leave that job up to us, and don't treat us like gods. Just treat us like we are humans.
Like, very well said, Shreya. Even I hated me treating less gods, and like, no, they actually public have a picture, like they have a guideline how a doctor should be. Well, that's not the reality. We're also humans. We can do mistakes, and there are like, it's an emerging field. You learn everything, like every 1 hour something is changing in our field, and we are not robots to have everything update. So people should understand that. I guess Samyukta also raised her hand in between. Samyukta, have anything to add on?
No, I clapped in between.
Okay. So let's move to the next speaker. Now this goes to the team Garage. Like, I read an article wherein they were saying like there is an increasing rise in LSES just because of practicing defensive medicine. So like, no, just being defensive, we start doing different surgeries, very fancy stuffs, and like, which is actually not necessary in most of the conditions. Like, what is your view on that?
So again, when we've spoken about defensive medicine, we are coming to the human element here. We've spoken about government schemes. We've spoken about insurance insurance coverage. And we have come down to the fact that, doctors are allowed to make mistakes, and doctors are not in fact gods. So we do understand that there's a human element that exists in medicine, right? The patients and doctors are both humans. And as with two humans in any situation, there are different perspectives. So, it's very interesting when Shreya and I sat down and we looked at this prompt and we decided to Google it. We found 2 research articles, and those research articles in themselves were contradictory. Whereas one said that, whereas one drove home the concept that there is something called a defensive cesarean section, which is different from an elective cesarean section. And in fact, if we go by the results of that particular study, defensive cesarean section rates are actually rising. Okay. But with respect to the other study, what the other study says is interesting. It says that whenever you do a surgical procedure, it increases your liability as a doctor. And hence, because of liability, so here again you see, so because of that increased liability, which you would call defensive medicine, the rates of cesarean section are actually coming down. So you see, it's a matter of your perception. If you see, different studies, different opinions have come in when the research has been done, right? It is two articles that speak about the same concept, use the same demographic, are saying 2 completely different things. Moreover, increase in a surgical procedure may also be due to constantly evolving protocols. Like if you talk about breech presentation, 5-8 years ago, according to what we've been taught, 5-8 years ago, there was this Hannah's trial that came out, which said that it's perfectly okay to do a cesarean section for breech. And that trial was widely published. So the rates of cesarean section went up like crazy, because if there was a breech presentation, you did a cesarean section. But now that's not the norm. So then again, cesarean sections are coming down after 5 to 10 years. So, empirically, if you look at the rates of any 2 surgeries and you were to decide that, okay, this is increasing because doctors just, don't want to do normal vaginal delivery because there are a lot of risk factors and they're practicing defensive medicine, not true. there are a lot of factors, right? And there's also this concept called elective cesarean section, wherein the patient themselves opt for the cesarean, right? And autonomy is at the center of bioethics. So yeah, that's the human factor, I think, and the different perspectives that we have to consider when we look at the rise in the rates of any surgery. Shreya, do you want to add anything?
Not much. I just have to say that, you know, yeah, I mean, maybe the rates of defensive LSCS are rising, maybe they're not. There are conflicting views, and, you can't always find a very, a definite number or a definite statistic. But, all I have to say is that, just riding onto the point that I had said earlier, that the doctor-patient relationship is at the core of it, and there are a lot of core values that have changed, which have led to the increase in defensive mechanism. And we need to get to the core of it, is that LSCS, or your cesarean section, your lower segment cesarean section, is a relatively new procedure, and all Stone Age babies and your grandparents and all, they have all given birth via normal vaginal delivery. It's a relatively new concept. So for it to actually rise, and for doctors to actually think that, there are certain studies which say that, the lack of feeling that, I am, skilled enough to carry out a normal vaginal delivery, which is how normal childbirth actually occurs. For them to actually not be confident in that, we have to think of what exactly the problem is, that that the confidence of a doctor is being challenged, and how exactly the dynamics have changed for us to actually have to resort to an LSCS rather than something that was being done for ages and centuries.
Yeah, like when Chetna said, we have the autonomy of choosing between a normal vaginal birth and an LSAS. I just got remembered of my sister. She actually, the doctor said she can have a normal vaginal birth, but she refused and she took an LSAS of her own. She said, I want only LSAS. So yeah, we have people in the same, obviously everything has every coin has two sides, and the one side of people choose by themselves. And as Shreya rightly said, we had to look if the doctors are competent enough in all the proficiencies they have to have. And I guess our new curriculum have doing it in a great way. We have competency based medical education and all. I hope everyone will have hands-on experience in all the techniques, the traditional ones and the upcoming new laparoscopy, LSAs and all that. So this brings to the conclusion of the session, and let's have an open session for questions from the audience, council members and the unit members. So I wish Meenakshi to take over.
Hi everyone, can you hear me? Can you guys hear me? Okay. Now, anyone can answer. It's an open field. Okay. The first question is, what are some of the potential problems that can arise as a result of defensive medicine? Could you hear the question? Okay. Yeah. Shreya, go ahead.
I answered a part of the question. That, I mean, the answer is wide, and it depends on what kind of defensive medicine you are actually practicing. Like Abhishek has said, there's negative and there's positive defensive medicine, and Snigdha rightly mentioned that there is a place for each. One of the harms that I think the defensive mechanism, when I think of defensive mechanism, I think of unnecessary investigations, and I already said that it is extremely distressful to the patient to actually undergo. For me, since mental health is not given much priority, I feel like even with a let's take for example, since I already mentioned it before, from master health checkup, you find an incidental nodule on your body, and it creates a sense of panic. I think this was an episode on House, where they had a House of one of the medical dramas where he had a master health checkup. They found an incidental finding, and they didn't know whether it was cancerous or if it was benign. It was most likely benign, as most a lot of conditions are. But that the thought that, it could be cancerous, it could be this, it could be that, then going through further investigations. And, you see where I'm going. It's like cycle, it's a vicious cycle. So that is one thing, the mental anguish, the distress that can occur. Just the burden on healthcare, the cost, the limited resources in India, especially. We might be from a higher socioeconomic class. I am, so I might not understand what a person from the rural perspective goes through, but there is a lack of resources, and practicing defensive medicine in those resources can be, of course, it can be distressing to the patient in terms of cost. It can be a burden on the healthcare. We don't have enough resources to handle that. And, also talking about the doctor, I just feel like, defensive medicine, while it might be defending them from litigation, you never know when it is going to lead them to that. So, yeah, I think these are just a few of the effects that can, occur because of defense mechanism, medicine. I don't know why I'm saying mechanism. And, it's just an endless question, and the answer is infinite.
That was very well answered. Manasi, you would like to add something?
Yeah. So another point that I'd like to have is, it does, like, few procedures do put patients at more risk when we are doing invasive procedures, or if we are exposing, like if you are doing too many MRI, CT scans, we are exposing the patient to a lot of radiation. So again, it can put a patient at risk. And sometimes maybe the patient comes with one complaint, and because we do this multitude of tests, we might see tiny, other problems which are not symptomatic, which are not causing an issue to the patient currently, but our mind would get diverted, to those tiny issues. So yeah, like for example, there has been a study where in coronary artery occlusion, there was no benefit like over non-invasive treatment. Putting stents has no benefit over non-invasive treatment, yet all the doctors would recommend putting a stent. Now, I would not say this is wrong, but it does put patient at some risk. Again, it is a operation, right? But this is, again, they do it so that in case the patient passes away in the future, then they have provided the best care that they could. And it would also relieve the patient of anxiety that, okay, I have received the best care from my doctor. Yeah, so that it does put patients at extra risk sometimes.
Thank you, Manasi. And now Chetna would like to add something.
Yeah, very briefly, because I think most of it has already been covered beautifully by Shreya and Manasi. So again, considering the human factor here, and, the trust between the doctor and the patient. Now, because we know that Shreya said that people are using WebMD, Google, and also they are aware to some extent of, what procedures and what investigations are needed in a particular scenario. So if they were to determine, or they were to realize that, the doctor has performed some procedure or some investigation unnecessarily, at the end of the day, it also taints the doctor-patient relationship, which further alters the trust in the healthcare system, which again leads us to that vicious cycle wherein, doctors are apprehensive, patients are apprehensive, and it propagates that scenario wherein, it's a soil for breeding violence against doctors, or violence in general, and loss of faith in the healthcare system. So it creates a divide between the doctor and patients, which should not be happening. So that's what I wanted to add.
Thank you. Now I would like to go to the next question. Oh, you have something more to add, Chetna?
No.
Okay, sorry. Okay, now the next question. As all of you have mentioned about the effect of socioeconomic aspect on defensive medicine, due to the high cost, people from low socioeconomic class would be negatively affected because they could not afford the treatment options. Is there anything that we as doctors can do to reduce the burden on them? Yeah, Chetna, go ahead.
So again, for the again, referring to personal anecdotes, whenever we write investigations and treatment as a final year medical student, now again, I comment as a medical student, so I don't know how much of this is, actually implicated in practice, in clinical practice. But whenever we discuss investigations and treatment, we have this tendency for stroke and all to write CT, MRI, or even for sometimes for pneumonia, people will just write CT chest, and then our teachers will be like, do you have any idea how much a CT scan costs, how much an MRI costs? And that's not defensive medicine. That's because they genuinely cared. Specifically in our hospital, we have a G block, which is the teaching section of our hospital, and where below poverty line patients are treated under government funding, partially government funded. So that's where we do our learning. And teachers are like, if you write CT, MRI, the patients are never going to come back to you if you write such high-end investigations. And that's why, when we are taught in medicine, we are taught very basic things, and we are not taught to be dependent on investigations. We are actually taught to be dependent on a history and clinical examination. Again, I'm well aware that maybe that's not what's translating into clinical practice, but I hope that as a new generation of medical professionals, maybe we can, take this into consideration and, sort of help more of this get translated into our clinical practice and be more dependent on our clinical history and our examination findings to sort of, lessen the burden on the patients. But again, even if you consider doctors, like Manasri mentioned, doctors in India are not very aware of malpractice insurance. And she also mentioned that there's no cap on the amount of compensation that can be rewarded. So, yeah, compensation that can be rewarded. So again, the doctors are also not, what do you say? Okay, for lack of a better analogy, Ambani's doctors don't have countless cash flow coming in. They're also human. They also have families to support, and they're not this bottomless pit of money. So their socioeconomic status also has to be taken into consideration when you sort of talk about defensive medicine, right? So that's it from my side.
That was so well put. I can totally relate. Like while presenting any case, even in college, for investigations, I tend to Google the latest investigations and write to impress the teachers and all. So I could totally relate to that. Okay, coming up to the next question. Does the level of knowledge and communication skills in the field of medicine that we have today compared to what doctors had 10, 20 years back impact the doctor-patient relationship and communication? And how important is this communication in defensive medicine? Yeah. Yeah, Shreya, go ahead.
Yeah, so I think the answer to that is a definite yes, for the sole reason that, like Chetna mentioned that as medical, sorry. Yeah. So like Chetna mentioned, as medical students, we depend primarily on history and examination. And now, there are a lot more people if I go to a clinic, if I have to go to a doctor, let's face it, they sit me down and do they ask me what my family history is? Do they ask me each and every medical disorder? Do they actually have the time to sit and ask me name, age, address? And, in the way we write a case sheet, no, they don't. And I don't blame them, because there are 20 to 30 other patients sitting outside, and they have to go home to their families, and they have to also pay attention to the patients that are outside, and they can't reserve how long is our medical viva, like how much time do we get with one patient? We get around 45 minutes to write a case sheet. They don't have that kind of time with one single patient. So yeah, definitely communication has changed a lot. And just the fact that in the olden days, a doctor, CTs, MRIs didn't exist. Now, like Chetna said, that we write CT, MRI, like just we write it to fill pages. Another thing we write is routine blood investigations. And we'll just say CBC kara do, take a CBC. And every doctor does that. It's like now you go to a doctor, no matter what you have, it's like get a CBC done. Nothing, then you come to know if you have anemia. earlier days they didn't have things like that to rely on. I don't have a lot of doctors looking down, seeing my palpebral conjunctiva to see if there's pallor. They just ask for a CBC. In the olden days, they had to depend on that. They had to talk to the patient and say, they have to see if there's pallor. Then they have to check for clubbing. They have to check for stuff like that. And so, yes, changes have been made and we had to rely on history and examination. I don't know how good, how bad it is, because I'm very grateful. I feel like medicine has, the sensitivity of our diagnosis has increased a lot since we have such investigations, and it has become more objective, because at the end of the day, one point that has been raised continuously is that we are human, we are tend to make errors, and our interpretations are subjective. So these investigations bring about a more objective point of view, so that it doesn't differ from one person to another. But at the same time, the communication is something that we have to work on. It is not, I don't think it is going to be the same as it was 100 years ago, or 50 years ago, or 10 years ago. It is going to keep changing. Teleconsultations, are becoming the new norm. You can't see the entire patient, you can't see like the entire patient's body language, something that a lot of doctors relied on a lot of years ago. And it's something that we have to evolve with, and we have to, but still I feel like a lot of doctor-patient relationships can be molded in a more effective way to come across, to make it a stronger and better environment for both the doctor and the patient.
That was very well put. Abhishek would like to add something.
Yeah. So I just want to add some final comments. Like, the more we talk, the more we understand the patient, and that's the basic of the patient and a doctor communications. And one more thing, before we don't have anything like no CT, no MRI, nothing, no radionucleic scans, nothing. But as we are progressing with the new technologies, since the sensitivities and the diagnosis of disease become more exact, more proper, but it should not be in terms of a cost of a patient's life. So if anyone is diagnosed with some rare disease or something like that, and that we are we are prescribing something, and if that guy is selling everything whatever he has, and he's investing in the medical procedures, and he's getting cured, but on the another side he just lost everything. So that should not be happen. So yeah, so communications and all this stuff is really important. In the first year of medical schools, we start with going to a patient, standing like long hours, asking the patient again and again, how are you doing, what's their histories, and we write each and everything. We have like small guidelines, things like, whether you have diabetes, yes or no, your family history, your mom, dad, how many children you have. So the more we talk, the better we understand, and it's the more we defend ourselves if we are talking about defensive medicine.
That was very well put. Now, Samyukta would like to add something.
Yeah, I agree with everything Abhishek and Shreya said, and they mentioned how important doctor-patient relationship is, and how in earlier days, yeah, they didn't have all these tests, so they had to rely on it. And I think with the previous question we were talking about income and the cost of healthcare. I think that also affects when you can't it has a drastic effect on poorer patients or patients of low socioeconomic costs. And when physicians sometimes I've also heard cases of where physicians refuse to treat low socioeconomic class just because they know they can't afford the treatment. And I think that there is like a lag of there is no defensive medicine there. There's negative medicine, but in a very negative way again. And I think there should be like a balance between, like, there shouldn't be tension between the doctor and the patient. We should work on reducing the tension between the doctor and the patient, but at the same time there should be a scenario where the doctor is able to cautiously provide them with the proper treatment and the incentive that they need. And yeah, that's all I wanted to say.
Oh, wow. Okay, now moving on to the next question. Samyukta, your hand is still up. You want to add something?
Oh, no, sorry.
As Shreya mentioned about teleconsultation, as more and more doctors are practicing it in COVID era. What are the? She mentioned that as doctors cannot see the entire patient, so there is a possibility of potential malpractice suit. So what can we do to guard against it? Yeah, Shreya. Yeah.
Yeah, I think the solution to that, it's a little tricky, of course, because you're not able to see the entire patient. Sometimes a lot of our examination relies on touching the patient, and a lot of it we still do. Like if you go to a gynecologist is still going to palpate your abdomen, which you can't do via teleconsultation. But of course, a teleconsultation was created keeping in mind the modern changes and like the new changes that are coming up. Sometimes it is difficult for a person to travel from one place to another, especially keeping in mind the COVID protocols that existed. And let's be honest, a lot of the times we're just lazy, and we want to stay at home and do everything and have it at a fingertips. It's just become very convenient. Now, if you have to ask me, I would attend an online session, and I would just want to forego the offline thing, because it's become convenient. Zoom has become convenient, Google Meet has become convenient. But I feel one simple solution to it is, again, establishing a better communication with the patient. In this case, I feel a teleconsultation, if I have to take a teleconsultation with a patient, I would have to spend more time eliciting a stronger history. Spending, if I have to spend 15 minutes with an average patient, I would spend half an hour with this one, because, I can't examine you properly. I will spend the time that I would spend examining, telling you, asking more history and eliciting what exactly is going on, and taking a more in-depth take on the situation. That is something that needs to be done. Of course, I don't think that the teleconsultation calls for more investigations, or, calls for more more defense, I would say. And also I feel like, if the situation is actually that bad, if you are teleconsulting, and if your disorder is such that I need you to come in, I need you to see your abdomen, or I need to see, are you okay, is everything okay, then nothing ever beats a physical consultation. And because like they say, a doctor's touch, nothing like a doctor's touch. And while teleconsultation is something that is a very good advance, we should move with the times. Definitely, you can't stay behind, especially in our field. I also feel like there is nothing like a physical consultation, and I don't think anything can ever replace that.
That was very well put. Abhishek would like to add something.
Yeah. So we're talking about teleconsultation. So I'll say it's better to have something instead of having nothing in this COVID era. And as we are progressing with the technology, we should have everything at the same time. So teleconsultation not only we should be based on the artificial intelligence and the modern methods, but we have to bring back the old things that we have mentioned in the previous comment on the patient-doctor relationship. So it should be a mixture of both. But as Shreya said, yeah, like physical touch is a physical touch of a doctor. So no one can beat that.
Well, thank you, Abhishek. Chetna would like to add something. Chetna, you're on mute.
Yeah. Can you hear me now?
Yeah, I can hear you now.
Yeah, interestingly, we all see telemedicine as this new concept that is coming because of how widespread it is. But honestly, I've seen my parents do it all the time, because as a kid, whenever I had fever, I couldn't possibly be near near my relatives who were doctors. So we all have that tendency to call up our relatives or our friends who are doctors and tell them, okay, my child has this. And I'm very and they'll sound all worried, and they'll write some medicine. Again, let's not going into ethics of it. What I would like to highlight is that the trust factor there is so high that, you talk to the doctor in your family and you trust them so much that they'll tell you a medicine. They haven't even looked at me. Come on, I have fever. They haven't looked at me, but they're writing medicine, right? They're writing a medicine. And my parents are like, somebody's parents are ready to give their child that medication. So that's the level of trust that's there that was there in the system, right? That used to be pehle ka telemedicine. And now when we talk about telemedicine, we have to think about liability, we have to talk about consultations, appointments, etc. And, also telemedicine is limited in its use with respect to certain procedures. For example, something that falls in my direct domain is actually abortion. So last year we were researching on COVID and how, am I still audible? Oh, all right. So COVID and how, that affects abortion, because that brought into this picture of healthcare, this self-managed abortion and telemedicine. So, there was a set of clear guidelines that we could find, and there was like this beyond this much weeks, obviously you can't do teleconsultation because you don't know what the risk factors are, you don't know what complications can occur even in a self-managed abortion, right? So while telemedicine is limited in its use, it has been in use for many years, right? So again, maybe, to sort of increase the faith of people, maybe we as medical professionals can come up with a set of guidelines that guide teleconsultations and, share them with the public that, okay, and provide more awareness, that we can't consult on all problems over this teleconsultation platform. Because like Shreya said, nothing really beats a physical examination. So that's basically what I wanted to add.
Thank you, Chetna. That was really nice. Now, the next question. What are some of the countries that already practice defensive medicine, or what countries are doctor friendly, as we call it?
Yeah. So going back to the countries which practice the defensive medicines, the developed in the medical healthcare, you can tell the US. So 60 to 80% of the doctors that you can literally see that they're practicing the defensive medicines. But there are other countries such as the UK, Australia, and other countries like developed countries that developing more to understand the pros and cons. Even though the government, even though the US laws are like very strict. So if a person tells, okay, this doctor has done me this thing wrong, and if they found it, so they're gonna compensate a lot. So there are countries that has already the defensive medicines, but some countries there's a various research that has been in the UG and the PG medical student, I guess in Norway and Jordan, I guess. So they were also talking about introducing into medical curriculum. So they are planning to have a more systemic way of a medicines rather than what we have, like going and allergic someone like, okay, this thing happened is because of you. So like, and I don't know how far India is into this, because it's really a new concept. It's already happening in India, but no one gives more importance to it. So we have to look back into the countries, we have to look back into the guidelines and the government, what they want. So yeah.
I think Manasvi would like to add something.
Yeah, so for the previous question, I think Meenakshi asked how to prevent malpractice during telecommunication. So adding to that point, I would say proper documentation. Always have proper documentation with proper serial numbers. This is what my professor stressed on. And have have all the telecommunication sessions recorded. And again, like Shreya and Chetna already said, proper history taking will again, proper history taking will help. And telecommunication only plays a small part of the diagnosis. But again, for our own defense mechanism or something, proper documentation. I think this applies everywhere, whether it's online or offline, which is not stressed upon here in India.
Yeah, that is true. I think a point of corruption also came back earlier, and yeah, I think this supports that. And regarding what Abhishek said, it's wonderful that these countries are coming up with proper schemes and procedures to to like regulate this. Let's just hope it comes back in India as well in a few years by the time we graduate.
Okay. Okay, this is the last question of the event. A post malpractice case, any doctor, self-esteem and his entire personality will be affected. And how can he cope with his self-image, and how can he fight against his public image? Like, he will view his every patient as potential malpractice case. So he, in his like, self-esteem will be affected. So how can he deal with such a personality crisis? Go ahead, Shreya.
Hi. Other than, there being an element, of course, that, better communication and, again, the same points harping on, I feel like, the more experience we gain as professionals, I feel like the moment I sometimes I feel very weird, like I get confused, like with one simple patient, or if I have to diagnose them on the bedside and I have 45 minutes with them, I'm still so confused with the diagnosis, and it scares me to tell the professor that, I'm scared that, what if I'm dealing with a real patient and, I mess it up somehow. So I feel like, such things, they come with experience. First of all, for any young doctor, I'm still a student, so I don't know how, well equipped I am to say that, but I feel like practice makes you perfect. I can't think of a better quote for that. I just feel like practice makes you perfect. That yes, of course, things have changed a lot, and the communication that we have with our patients now is very different from what our doctor parents or our older doctors have had with their patients, and the dynamic they shared is very different from the dynamic that we will share. But I feel like a lot of things can't be spoken. A lot of things can't be taught, and it's something that you learn through experience, through the tiny mistakes that you make, through the patients you see in the ward. And I just feel like it just reminds me that every single time, I don't know how many of you relate to this, but every time I make a mistake, I make a stupid, silly mistake, like how you'll go and you'll put the BP cuff on the wrong hand, or you'll check the pulse on the wrong side of your hand, and you're scared, or you'll say something really stupid, and you're so scared of doing that. But every time, a teacher yells at you, I'm not saying it's right, but every time a teacher just says, you're stupid, you don't know anything, you're gonna fail, or stuff like that, I never forget that. I don't know how relevant it is to this, but it just speaks that experience and the learning and the mistakes you make are going to change you and shape you into the doctor you are going to become. And I just feel like if you learn from those mistakes, you take it to your heart, and okay, this is what I did this time, I have to learn from my mistake and not do it the next time. I feel like that is what is going to shape your ultimate personality as a doctor, because every doctor has a different personality. Some doctors are the cool doctors, some of them are the strict ones, some of them are the really scary ones. Like I go to some doctors and I just get this vibe, like, please get me out of here. And some of them they're like my friends, and they're really friendly and sweet. So I feel like, yeah, like, just going back to the same thing, that your experiences are gonna shape you into the doctor you want to be in the future.
Wow, thank you. That was totally relatable. Now, Chetna would like to add something.
So I think this is a process that, as Shreya said, it starts from medical school itself, because because how many times when we failed, or we say that we're going to fail, our friends have come and told us that it's okay if you fail, it's not the end of the world, and it's not going to determine your career as a doctor, or it's not going to determine how good a healthcare professional you are. So how good you are as a doctor is not determined by the mistakes you make. Basically, like Shreya said, it's sort of framed by, even though it sounds philosophical, it's actually true. It's actually determined by how you deal with those mistakes. And one good thing about the medical fraternity is that, from what I've seen and what I've uh, observed, and what I see with my batch also, when there's any crisis, be it a minor crisis or a major crisis, the batch or the fraternity comes together. You see, there's National Black Day observed when there's violence against doctors all over India. So one good thing about medical fraternity is they are a very close-knit fraternity, and you form a very good and closely knit support system in the healthcare world. And that, I think, can help you to some extent to recover from a mistake that you've made, right? And ultimately, the realization, you have to realize that it is not the end of the world. Apart from this, like we, like Shreya said, that mental health is not really given a lot of importance in our part of the world, but it should be, right? So counseling services or any sort of mental health support to doctors who are recovering or who are coming back to work after a setback, should be extended, I feel, because the healthcare system is already so overworked. There's no need for us to lose existing doctors, right? So yeah, that's it from my side.
Wow, thank you, Chetna. Does anyone else like to add something before I hand over to Samyukta? Okay. Samyukta, you can take over.
Yeah, okay. Thank you, Meenakshi. I think I just want to bring out a case. I think Manasvi and I were discussing about this earlier. There was this case, I think a day ago in the newspaper saying, so this lady who was born with spina bifida, the neural tube defect, and she sued her mother's doctor for a hefty sum of money that the doctor failed to advise her mother to take folic acid pills earlier during the pregnancy, and for letting the baby to be delivered in that condition. And she sued the doctor and she won the case for something as trivial as important as folic acid tablet that forms like the basis of any pregnancy in the early stages. And this happened a few days ago. So what do you guys think about this? Was the patient right in suing, or was the court right in appealing this case, or was the doctor actually in fault for the patient not taking folic acid pills? In India, we do have that huge problem, women not consuming iron or folic acid pills. So what do you guys think? I think Chetna, you can go ahead.
See, again, actually, it's very interesting that you brought this up, because we read the case as well. And yesterday I was reading this out to Shreya. And the article sort of just reads that, woman sues the mother's doctor for being born. And I just looked at the article headline and I'm like, what, what is even happening in this world now, like, children are suing the doctor for just, for the doctor allowing them to be born. And again, when we sat down to, to discuss the panel discussion today, we again saw the case. So I told Shreya, I'm sure it's not this. There is an explanation, a detailed explanation of why she chose to litigate and, why she was awarded the money. But the perception, you see the perception from that one article, from that one statement, the power of that statement, to think, okay, patients can do whatever they want and doctors are going to, sort of fall through the cracks, and they are going to have to pay up, right? Whereas there's a perfectly good explanation. So I know I didn't really explain to you what my stand on this case is, but what I wanted to bring out is, the perspective, the way in which things are conveyed is also a reason for us to perceive defensive medicine instances increasing, surgical practices increasing, medical negligence increasing, right? If that article had been framed differently, maybe my thought process would have been different, is what I'm thinking. So that's like what I thought when I read this article. So I just wanted to, sort of share that here.
That's very true. I think when I read the article, I was like, "What? What the hell?" And I think that is why the entire article gained the attention of so many people. So many people were talking about it. And yeah, Manasvi, you can go ahead.
Yeah, so even I was clickbaited by the headline, and I was like, "Oh wow, now we can get sued for such petty." I don't know. I don't know if it's petty or not. It's just a very weird thing to get sued for, right? And then I don't think there are much details about the exact trial in the case. It's just the doctor did not tell her to take folic acid. But we don't know if he did tell her and she didn't take folic acid. In that case, it is patient negligence. And I think in India, that could be a defense. It could be used as a defense for the doctor. When it's patient negligence, it's not doctor's liability. But then again, I'm really curious on how this case proceeded. I really want to hear from the patient's attorney. What did they do to win? Because I think it was $2 million or something. Yeah, that's a huge amount. And folic acid tablets, I'm just surprised. I really need to know the defense. Like, he's a good, either the doctor's defense was very weak or the patient's attorney was really good, because this probably happened 20 years back. Probably limitations have expired. They have to dig up evidences. I'm not sure if they had documented if the patient had taken folic acids 20 years back. I'm not sure if the mother remembers if she had taken folic acid 20 years back. It's controversial.
It is very controversial, and for the case to be happening after so many years, the lady is, fully grown. She's an adult, and it's kind of crazy to see how far back, the story goes. And yeah, I think we should dig further into this. Yeah, Shreya, do you have something to say?
Yeah, I think just building on what Manasvi said, first of all, wow, modern journalism, because I think it was the headline. And, like Chetna said, we were just looking at the thing and we were just disgusted for a bit, because I don't know how else to explain it, because like, why would you sue a doctor for something like that? Like, okay, cool. And, we had a long discussion and we were laughing about it and stuff like that. But like Manasvi said, it could go either ways. It could be that, the patient wasn't compliant. I don't even know if, since it happened so long ago, forget the mother not remembering whether she took tablets or what. I don't even know whether the doctor remembers who the patient is. Because, she's giving birth to so many children, and I don't know, maybe she remembered, maybe she didn't. It's like very very sad to be sued by someone who you possibly do not remember, because we do come across a lot of patients, right? And it doesn't mean you don't care about the patient, it just means that maybe you don't remember because it happened such a long time ago. But again, coming back to the point is that it could be either way. Either the patient comply, in which case, the doctor did everything they could. They told them, they prescribed the medicine, or it could be that, they genuinely didn't, just forgot to, tell them that, you do have to take folic acid prenatally. I was just reading the case today. I think she forgot to prescribe prenatal folic acid for the mother who was trying to conceive. So again, I'm not sure, but that's what the article said. And, in that case, of course, it is medical negligence. I feel like, yes, of course, patient negligence is not the doctor's mistake, but, when something like folic acid, for those of you who are well equipped with obstetric history, that's like, we have the trimester history. Each trimester, the first trimester, I'm folic. That's the first thing we do. And that, as medical students, we have been taught that since second year. I know this since I was in second year in our posting, because that's the first thing that was drilled. And, we all know it causes spinal deformities, it causes spinal deformities, the folic acid is absent. So it's a very basic thing for a gynecologist to not prescribe that firsthand, knowing that the incidence of folic acid deficiencies is higher and it can lead to a lot to spinal deformities in the infant is a case of medical negligence. And I don't think that anything, like I said, the responsibility, this is gross negligence, and I feel in this case the doctor is responsible. I don't know if the sum, I'm not a lawyer, I'm not going to give my legal outtake on this, and I don't know if the sum of 2 million is too much, too less, whatever. But and I feel like defensive mechanism, just defensive medicine and negligence are two very separate entities, and they don't meld together in any way possible. And we like any healthcare professional, for that matter, should be held responsible for mistakes such as these. They should be held responsible, because yes, mistakes are very humanly possible, but also you have to understand that yes, mistakes are okay. I understand, like, small boo-boos are okay, but this is not a small boo-boo. You changed an entire person's life, and the person is now living with a permanent defect, and they have gone through 20 years of their life before they probably realize. I don't know how she came to the conclusion that, okay, folic acid wasn't given to my mother, and she thought of suing the doctor 20 years later. But she's lived 20 years of her life with a deformity that she cannot correct, that the person cannot correct. And I feel like if the verdict is that, if the verdict is right, that she actually didn't even mention the fact that you need to have folic acid, just say that you need to have or prescribe the folic acid tablets, yes, then in that case, I feel like punishment is due.
Yeah, I agree. I think the original case was that the doctor failed to tell her to take folic acid tablets before conceiving, right? So the mom could not delay the conception, and that is where the entire it's kind of like a loophole. We have no idea what happened there. It's like a blind thing. But yeah, I'm very glad this was discussed extensively here today. And I think this brings us to the end of the session. Thank you everybody for being here today. I think we learned a lot of different perspectives. I didn't expect to have so many differing opinions, and I think it was very interesting to learn from each one of you, because each one of you had a very a clenching point to deliver, and I think it definitely benefits us and everyone watching us on this live, or whoever sees this video later. And I think it did change the way we look at this scenario. As it's as I think Snigdha mentioned, it's a necessary evil, defensive medicine. You have no idea what can go wrong, and it's yeah. And I think this just brings us to the end of it. I thank all of you for taking the time to be here. Shreya, Chetna, Manasvi, Abhishek, and I think Snigdha left, but there's Snigdha as well. And thank you for accepting my invite and attending today. And thank you mainly to my co-moderators, Vashni and Meenakshi, for doing such a good job today. And I think it was very great to have you here. I think we should have more discussions on similar topics, where there's just it's very new, and it's not talked about much. And I think it was very beautifully put by all of you, every single opinion. And you guys represented your council point of view is also very well. And I think that's it. Thank you so much. If you guys have any words, we'd like to hear that.
Yeah. So I feel in these situations, there's a lot of things that violence against the doctors is going on over the India with protests for different causes. Yeah, I guess. So everyone need to discuss more about this, but we need to find some evidence, like why it's more than discussion. Also, we need to find why it is happening and how can we resolve that. So that's the thing that we can, and we have to make our systems better, the laws better to prevent the negligence, and we have to be more careful because in the future we are going to be physicians, so we have to learn from the mistakes. Whatever we are doing now, see, we are discussing now about all medical defense, but there's a lot of people who doesn't know about this actually. So if in futures we'll be more aware, okay, fine, this is something that we have done like before 5 to 10 years before us, and see this actually happening here, and government has actually made that rules and regulations to proper follow. So if you look into back something, like we should be highly proud what we have done. So more lights and more advocacies on this topic is needed definitely for the medical students who is undergoing now, and for the doctors who is already like practicing it. Yeah.
That was very well put, Abhishek. Thank you everyone for being here. Anybody else would like to say anything?
Thank you, Samyukta, for organizing this panel discussion. And when you reached out to me, I was first a bit skeptical. I'll be honest, I wasn't exactly sure what defensive medicine was. I've heard of it, but never dwelled deep into it. And because of this panel discussion, I feel like I've done a lot of research, read tons of articles, and now I know, like, oh, this is what's happening, and it has widened my perspective. And again, listening to Shreya, Chetna, Abhishek, and Snigdha, they've put out very good points. Again, I've just entered clinicals. I've just started going to the hospital, and this is why my I'd say experience is very low compared to them. So I wasn't sure on how will I speak today, because I don't have much experiences from the doctor end, right? I just have experiences from the patient end, but now, again, widened our perspectives.
Thank you so much, Manasi.
So again, I think Samyukta, you've done a great job with this discussion, and you are doing a great job with the unit, and I would like to thank you for this opportunity and for the invite as well. And whenever we have panel discussions like these, I think it gives us a chance to interact with each other, and allows a more open and free exchange of ideas, and we all learn something, right? And we all have something to take away. So I think Manasvi, Abhishek, and Snigdha, again, they're great speakers, and they always have great perspectives on topics. So it's always like a good experience to listen to them, and it is a learning one, I feel. So thank you, everyone.
Thank you, Chetana. Thank you so much. Would my co-moderators would like to say something? Okay, all right. Then I think this is the end. Thank you all so much for attending. So bye-bye. Good night. Have a great week.